specific wording of the criteria because you can read that in the book, but really give you an idea about why the DSM-5 is what it is, why the decisions were made to include or not include some conditions and how their criteria were developed. The controversies that came with it. So in terms of disclosure, I have no financial relationship with the industry. I did get one free copy of the DSM-5 from the APA for the contributions to the DSM-5 process. So I'm going to start with a general background about the DSM-5. I feel that I have somewhat unique perspective, both as the chair of the Neurocognitive Disorders work group, but also more importantly, as Laura said, as the immediate past president. I was the president during the time that the DSM-5 was finalized, approved, and published. So I'm going to tell you more about how this happened. Then I will talk about, of course, the neurocognitive disorders. Within that, mainly focusing on the major, which is dementia and mild, and then very briefly about associated behavioral disturbances, and finally summarize the finding. Okay. So this is the DSM-5. Many of you have seen it. This is the other DSM-5, where the D stands for dartboard, and DSM-5 has been subject of criticism from every single angle ever since it was conceptualized and continues to happen after its publication. So why is that so? And I'll talk about that too. Okay, so let's just go back and think about what is diagnosis. The word diagnosis means thorough knowledge. So the idea is that when you mention a certain condition, you would know the nature, the causes, the course, possible treatment by studying the symptom. A good example of that is streptococcal pharyngitis. So when you talk about strep throat, we all know what the symptoms are like. There is cough, cold, high fever, the throat is red on the examination, and then you do throat swab, you culture strep, and then you treat it with penicillin or whatever the newest antibiotic there is for strep, right? So that's the usual goal of a diagnosis. When you say strep throat, you know the whole thing. Unfortunately, that doesn't apply to most of the chronic complex diseases in general. For example, diabetes. The diagnosis of diabetes doesn't tell you anything about exactly what kind of a patient you may have. Patient may be in diabetic ketoacidosis or may have very mild diabetes. When it comes to mental illnesses, actually it becomes even more complicated because here we don't know the etiology in most cases. The course is highly varied. And think about schizophrenia. And there are no valid biomarkers. We can't diagnose schizophrenia by examining blood or looking at MRI, right? So that's why the diagnosis becomes much more of an issue for psychiatry than for some of the other specialties. So what should the diagnostic criteria be like? Clearly, they should be standardized and operationalized. They should be reliable. What is reliable? There should be both test-retest reliability. That means if you repeat the examination in a week, you should come to the same conclusion, and there should be, more importantly, inter-rater reliability. If two different people saw the same patient using the same criteria, they should come to the same diagnosis. And third is, of course, it should be clinician friendly, because who will be using it? The clinician, right? These are the things I think that DSM mainly aims at, because the next three things we cannot do in most cases. Valid. The validity means that we have to prove that somebody had the diagnosis based on something else. For example, we diagnose cancer and then we can see the cancer cells in the blood, or we diagnose stroke and we can see that in the MRI. That doesn't hold true for schizophrenia, depression, bipolar. Same thing applies to how sensitive or specific the criteria are or their predictive value. At the same time, we don't need to feel too bad. We are not the only specialty. For example, migraine is a major neurological disorder, but migraine has no biomarkers. The diagnosis is clinical, and there are a bunch of other conditions where the same thing applies. Nonetheless, they apply more so to psychiatry than other conditions. at this time. Okay. So the history of the DSM, the American Psychiatric Association, actually right from the beginning when it was founded back in 1844, has focused on statistical epidemiological studies of mental illness. That's why the word statistical comes in this diagnostic statistical manual. They wanted to look at the prevalence of what they call insanity back in the mid-19th century. The DSM itself first came out in 1952. It was not called DSM-1 because they didn't know there were going to be DSM-2 and 3 and 4. And then DSM-2 came out in 68. Both the DSM and DSM-2 were primarily based on psychoanalytic thinking. So they didn't call these condition disorders, they called those reactions. The DSM-3 really revolutionized psychiatric diagnosis because it said that the diagnosis must be reliable and operationalized. And I think that's a big change from the previous psychoanalytically based DSM and DSM-2. In between, by the way, one thing happened in DSM and DSM-2 included homosexuality as a mental illness. In 1973, the APA members had a referendum, and by majority they decided to exclude homosexuality from mental illness. This goes from the DSM, this goes to show how the social factors affect psychiatric diagnosis. The DSM-4 came out in 94, and really the goal there was not to make changes in DSM-3 unless they were absolutely essential. Okay, so why do we need DSM-5? So until recently we were using, or still someplace, we are using DSM-4, which is really based on DSM-3, which was published in 1980. That means we are using the diagnosis and criteria that are based on the science from 1970s. Clearly, in the last so many years, remarkable changes have occurred. We know much more about mental illnesses, so how can we continue using the same criteria? Diabetes, hypertension, obesity, examples where the diagnosis has changed, the cutoffs have changed. Cutoffs for blood sugar, blood pressure, BMI have changed based on the data. So why should we not also make appropriate changes? Another reason was excessive use of the NOS, not otherwise specified category. And lastly, there is a societal need or demand for changing terminology. Autism. When I did my psychiatry residency, I was taught that autism is very rare, and it is really type of early childhood schizophrenia, the most severe form. Today we know that autism is actually fairly common. The prevalence may be at least 1% of all the kids, maybe even higher. Bipolar in children, it's just the other way around. That the problem was that bipolar people thought was overdiagnosed, and kids were being treated with atypical antipsychotics when they should not have been. So the concern was narrowing the diagnosis of bipolar. I'll come back to gender identity disorder later. So there are demands or needs for changing the diagnosis, apart from the scientific issues. So why do we run into problem? Why all this criticism that we receive? The primary purpose of diagnosis is pretty clear. These criteria are meant for clinicians. That's the first thing to keep in mind. These are not for researchers. They are not for insurers and others, but primarily for clinicians to help really to reliably diagnose, communicate about, study, and treat people with mental disorders. That's all fine. The problem comes because of the secondary consequences, the unintended consequences, one of which is implications for clinical care access. If you don't have a diagnosis that the patient is suffering from a disorder and the diagnosis is not there in DSM-5, the person won't get reimbursed. Social stigma. On the other hand, if we label somebody as having schizophrenia or bipolar or major depression, the person may not get a job. Insurance benefit may be denied because mental health parity still doesn't exist. It is supposed to become law next year, 2014. Legal determination. You all know in the court of law, there is so-called insanity defense that's used. Medication. The FDA approved uses are restricted to specific diagnosis. Of course, ethical considerations, practical sequelae, as I mentioned, and so on. So it is the secondary consequences that create difficulties with changing psychiatric diagnosis. And so those create the challenges when you think about changing the criteria. One is you get very different, I mean the stakeholders clearly are important, but let me give you an example of the gender identity disorder, what is now called gender dysphoria, where a person in a man's body feels that she's a woman. So the transgender community, many of the people in that community did not want to have that in the DSM-5 because they said it's not a mental illness. On the other hand, the other half of the community wanted it in the DSM-5 because if it is not included, people won't get reimbursed for sex change operation. So you see that there are conflicting perspectives on the same issue. Issues of conflict of interest, especially related to the pharmaceutical industry, these have become, I mean, they are an issue for the whole of medicine, but I think unfortunately even more so for psychiatry because of some of the scandals that happened in the last decade or so. So anytime you, and that's also related to the stigma issue. So if somebody publishes a test that helps detect cancer early, say cancer of colon, prostate, breast, we all love it, right? That's why we do mammography, that's why we do PSA and so on. We want to diagnose so we can do something. When you talk about diagnosing schizophrenia early and the whole hell breaks loose, they would say, how can you label somebody when you don't know whether the person will develop schizophrenia, and so on and so forth. So that's where the stigma comes into play. And there are practical issues. When you change a diagnosis, issues about record keeping, changing clinical evaluation methods for the clinicians. And by clinicians, it's not only psychiatrists and psychologists, but clinicians, the primary care docs, of course, are the ones, but also even social workers, nurses, they use diagnosis. So all of them need to be educated in the changes. So it's not something one can do easily. Okay. So those are the general issues. The specific issues for DSM-5. First question is, should we require functional impairment as a necessary criterion? Take the example of cancer. If you find cancer cells, or if you find breast cancer on mammography, the person has no symptoms, would we not call it cancer? Of course we would call it cancer, right? But should we call somebody as suffering from mental illness when they are okay with their symptoms, so long as they are not severe symptoms? Probably not, because if we labeled everybody with any symptom of depression as having major depression, I think we would be accused of over-pathologizing the illnesses and so on. So we decided that functional impairment should be a necessary criterion. So that means we look at the disability. So should there be disability measure? In the DSM-4, we have the GAF, which is the global assessment of functioning. Excellent idea. The problem was almost every clinician gave every patient between 40 and 50 because otherwise the patient won't get reimbursed for the care. So it really stopped being useful. So we need something else, but should it be global or should it be disease specific? Person who suffers from schizophrenia has different disability than somebody who suffers from, say, OCD, right? So how can we use the same? So those are the issues. So what we have done in DSM-5, there are both disease-specific and global measures that are included in section 3. They are right now not mandated because it would be impossible for most clinicians to do complete evaluation in 15 minutes that typically they do. Nonetheless, this is something hopefully research will help. Originally, we were hoping that we would have neurocircuitry-based classification. For example, disorders involving fear circuitry or reward circuitry. But very soon we found out that most disorders, we don't know the circuitry. So that didn't work out. Multi-axial diagnostic system. The previously we had diagnosis on axis 1, 2, and 3. Really didn't make any sense. Why should personality disorders be on section on axis 2? They are serious as 1. And why should medical disorders be on axis 3? They still are similar to the psychiatric disorders when the patient suffers from them. So we removed those three, and there is now single axis. And last, whether we use the Roman numeral or Arabic numeral. This actually generated a lot of controversy. So why did we settle with this second version? The reason was that the expectation is that we won't have DSM-6. We would have incremental changes, so DSM 5.1, 5.2, and so that becomes harder when you use the Roman numeral. So APA decided more than 10 years ago that we are going to have DSM-5. So it's actually a pretty complex process. People often don't know about that. So they started with a chair, David Kupfer, and a vice chair, Daryl Regier. Then they formed a task force which included chairs of the 13 work groups. And so the chair of the Neurocognitive Disorders work group. But there were hundreds of advisors from all over the world who were there. Then there are lots of committees. There was a conflicts of interest committee because when the task force was formed, the media went back and looked at everybody's possible conflicts of interest, and they criticized the APA for being in bed with industry. So we needed actually conflict of interest committee which made sure that people, there's a very strict, they should not make more than $10,000 per year total combined, etc., etc. Then the process oversight committee, which assured that the process was going in a fairly democratic fashion. This is an important committee, scientific review committee, because the people who develop the criteria, so these are the work groups that develop the criteria. So 13 work groups for 13 different types of disorders, psychosis, mood disorders, neurocognitive disorders, etc. But any group of experts, when they get together, they develop the criteria, they're inevitably going to be biased by their own thinking, right? And so in order to make sure that the diagnosis that were and the criteria that were developed were unbiased, we had a separate scientific review committee comprised of high-profile scientists who were not involved in developing the criteria. But science is not the only thing for psychiatry. I mean, the clinical public health significance also becomes critical. There are many disorders, for example, sexual or gender-related disorders where the data are very limited, and yet clearly we need to include them. Forensic review, because every time you change a criterion that has major implications in the courts of law. And there were field trials to make sure that the criteria were reliable, and so there were consultants for field trials. So pretty complex process in which something like 3,000-4,000 people from all over the world were involved, and they included psychiatrists, psychologists, social workers, nurses, pediatricians, neurologists, what have you. Okay. So I'm coming to the close of this process, but I just want, as I'm thinking about the social anthropology, if you will, that this became an ultra-long process. Originally when we started, the expectation was that we will be done with in a few years and so on. And what was surprising really was the criticism that you received from outside. This didn't happen with DSM-3 and DSM-4 at all. When DSM-4 was coming out, there were just 1 or 2 articles here there, but mostly the field ignored that. DSM-5 was very different. As soon as it was announced, then and every person who was involved with that was seriously scrutinized and etc., etc. It's not wrong, but nonetheless, so the world has changed. Changed perceptions about psychiatry, unfortunately, because of this industry-related scandals in the last decade. I think psychiatry, I do think, is held to a higher standard. The whole pharma, I mean, pharma used to be much more respected 20 years ago. Now the idea is that mostly, there's a lot of unethical practices that go on. That's the thinking. And the whole organized medicine or the organizations as such, whether it is AMA, APA, or something else, people have become more skeptical. Impact on healthcare economics, again with the healthcare reform, cost has become a far more important issue than when DSM-3 and 4 came out. Consumer groups with strong influence. The best example is autism. The best consumer group that has ever existed, I think, in the history of medicine, I would say, that because of their strong advocacy, there is so much funding that is available. and unprecedented public scrutiny about review, transparency, conflicts of interest, fueled by social media. Social media didn't exist previously. And DSM-5 became the most reviewed diagnostic manual in the history of medicine. APA alone directly received 23,000 public comments. Just imagine that. Okay. So, my unplanned love affair with DSM-5, I had no interest actually getting involved in DSM-5. I was not involved in DSM-3, 4. I was leading a happy life. And so what happened actually, there was an international conference that APA had scheduled on dementia. The chair of the person conference couldn't, something happened and he couldn't do that. And so I was asked to do that. And then one thing led to another, it resulted in monographs. So then when they appointed the work group, then I was appointed as chair and member of the task force. And in the beginning I said, oh, this is great, nice honor, and then we'll be done with the review in a couple of years. And that's the time when we started hearing all this criticism. And then it became clear that actually far more work was involved than. So when I was elected as president-elect, I said I couldn't serve on that work group anymore because I'm responsible. And I thought that was a great relief. I could get out of DSM. But what happened, the year I was a president, that's the year that was the year for approval, publication of the DSM-5. Many people ask me, why did I choose to run during that year? Couldn't I have chosen a better year? But I didn't have the hindsight. Okay. So why? So, and really, this is the real picture. So when I became president in May 2012, really the picture looked pretty gloomy for DSM-5. The dumb bit of criticism in the media, New York Times alone published 10 articles within a span of 2 weeks. Most of them were highly critical, DSM-5. Even within the APA, there were major controversies. The people who developed criteria, people who reviewed them, major differences of opinion about what we should do. 2 anti-DSM books were already announced. One was by Alan Francis and another was by Greenberg. And those books, by the way, came out last month. There's a petition to boycott DSM-5 by counselors, among others, and other people. And it was signed, apparently signed by thousands of people internationally. There were threats of lawsuit by advocacy groups. They said if people suffering from certain conditions don't get reimbursed because they're not included, we will file a lawsuit. Some of the state legislatures decided to go back to DSM-4 and not use DSM-5. And last but not least was actually the real threat of congressional investigation by Senator Grassley because of the accusation that APA was doing something to help the industry sort of increase the market share. So that's the time I became president, and my charge was to have the DSM ready for publishing by December. The good news is that actually we did that, and I'm really proud of the way this did that. So the first thing I did was to form a summit group, which included representatives from all the major constituencies. There were 30 people. Imagine 30 people on a conference call, but it worked. And we said always the primary goal we have to keep in mind, this is for our patients. So this is really, that's the goal. It's not for researchers, not for anybody else. So must be clinician friendly. So we have to take into account science, but we also have to take into account consumer perspective. Frequent meetings, conference call, we work with the advocacy groups. Actually, we meet with people from autism group, the bereavement exclusion, so meet with those folks, and respect and reaching out to the critics instead of shunning them. I wrote an article in which I said Alan Francis had really done a great job with DSM-4, and that's what now we are doing with DSM-5. And setting and meeting strict deadlines. So with that, DSM-5 was approved unanimously by AP Assembly and the Board of Trustees by December. This was, I can tell you, this was unimaginable just 6 months earlier. And then this was the most rewarding part. May, when it came out, the New York Times editorials, it criticized the DSM, of course, and APA, but it did say that the DSM-5 is clinically state-of-the-art diagnostic manual. It said, this is the best we can do today. And then, of course, now it ranks number 4 on the Amazon.com's bestseller list, multiple printings. I'm not getting anything out of that except for a free copy of the book. Okay. So after all that general background,
$5,000.
yes, right. Yeah, so it will become, I can't be able to sell it. Okay. So neurocognitive disorders, why are they important? Because as we all know, the population is aging. This is what is called the aging pyramid. In the world, so just in 1970, not that long back, this was a triangle. So this is the age range. So that means there are many more children and young adults than older adults. This is what it will be in 2050. It becomes a rectangle. There will be more older adults than children under 15 in just a few years. This has not happened in the history of the world. So whether we like it or not, we are all going to be geriatric psychiatrists, psychologists, nurses, social workers. Okay. So I actually had the privilege of then forming the work group. So I was the chair until I stepped down in 2011. Then Dan Blazer from Duke, Ron Peterson, he's a neurologist at Mayo, they became co-chairs. Deborah Blacker, psychiatrist at Harvard, Mary Ganguly at Pittsburgh, our own Igor Grant. Jen Paulson, who used to be here, a neuropsychologist, now she's in Iowa, and Parvinder Sachse, an Australian psychiatrist. So this was a pretty diverse group of people. So when we started, so we looked at the DSM-4, and DSM-4, the category was called dementia, delirium, amnestic, and other cognitive disorders. We thought that was quite a mouthful. So we replaced that with neurocognitive disorders. So what are neurocognitive disorders? The primary clinical deficit is in neurocognitive function. We know that schizophrenia is associated with cognitive impairment, depression, bipolar, all associated with cognitive impairment. But they don't present with cognitive impairment. Those patients present with psychosis, mood symptoms, right? These are the patients who present with, and the primary deficit is neurocognitive. And secondly, there is a decline from previously attained level of functioning acquired. So this is to differentiate it from intellectual disability, developmental disorders, what used to be called mental retardation. So there are 4 conditions that are included: delirium, major neurocognitive disorder or dementia, mild neurocognitive disorder, unspecified neurocognitive disorder. I'm not going to talk about that. The only reason for having it there is whatever classification you come up with is never going to be complete. So you always need that wastebasket category. I'm going to spend very little time on delirium because there were very few changes in the criteria. But before I talk about that, I just want to talk about neurocognitive domains because, okay. So there are 6 main neurocognitive domains that are listed, and you'll find them in the DSM-5 book. They describe what it is and what tests can be done to test. So complex attention, this includes things like sustained attention, divided attention. Executive function includes working memory, decision making, planning, inhibition, learning or memory. The memory can be immediate, short term, long term. Language, both expressive language and receptive language. Perceptual motor, so the hand-eye coordination, clock drawing, and social cognition. So this is theory of mind. You can think about what somebody else may be thinking about, as well as compassion, empathy. Okay. So these are the neurocognitive domains that are involved in the neurocognitive disorders. I'm just going to very quickly go through that. The only difference, main difference actually from the DSM-4 here, was that DSM-4 said that delirium meant a disturbance of consciousness. And we thought that the term consciousness was really very vague. It's kind of semi-philosophical, and it's really not easy to operationalize. So we replaced that with attention and awareness. Other parts of the definition are very similar. This is short lasting, etc., etc. And okay. If there are any questions, ask me, but I think these are the 2 things I want to spend most time on now, major and mild neurocognitive disorder. So this is Alzheimer. Oh, okay. When we see somebody with Alzheimer's, the person is severely demented. I mean, obviously that person didn't develop Alzheimer's overnight. It was going on for a very, very long time, for decades. Typically, if you go back and look at the history of somebody with Alzheimer's, it starts out with what may be normal aging associated cognitive impairment. As we age, the working memory starts going down, the psychomotor slowing begins, and so on and so forth. Difficulty remembering names, faces, etc. So that's often the first stage. Then comes the stage of mild neurocognitive disorder, in which there is modest cognitive decline. And yet one can still perform the instrumental activities of daily living, and these include things like managing medications, making phone calls, etc. So that's and then comes the third stage, in which there is a significant cognitive decline with loss of independence in these instrumental activities of daily living. So this is a very nice progression, and that means that if we can identify these people at this stage, right, then we might be able to prevent it. Unfortunately, this becomes more problematic because, one, majority of the people with normal aging associated cognitive impairment will not develop mild neurocognitive disorder. Majority of the people with mild neurocognitive disorder will not develop major neurocognitive disorder. So that becomes a problem. So if we say here at this stage that this may be early Alzheimer's, or even here that this may be early Alzheimer's, we would be labeling people when majority of them are not going to develop Alzheimer's. Another problem is not all dementias are progressive. For example, TBI, traumatic brain injury, when that causes cognitive impairment, there is a decline from the previous functioning, but then the decline, that impairment stays pretty stable. So the main controversies were these, and so these are the issues actually that we had to struggle with. Okay. One was, why should we categorize when we know this is a continuum, right? Aging associated, normal aging associated cognitive impairment, then we go to mild, and then it becomes major. What do we need to, why don't we just look at the degree of cognitive impairment, right? So that was one issue. Second issue was, some people didn't like the term neurocognitive. They said, why are you switching from cognitive to neurocognitive? Is there any such thing as non-neurocognitive cognitive? The third was, we wanted to use the term major neurocognitive disorder, and some people said we have to use the word dementia. And some people said if you don't use dementia, we will boycott DSM. And there were others who said if you use dementia, we will boycott DSM. These were different constituencies, and actually they all had, again, there was a rationale behind it. Talk about that. And the last was, should we require neurocognitive assessment? Okay, I'll go through each of those. So the first one was continuum versus categorization. And clearly it is a continuum, but in real life we have to have categories. Why do we decide that voting age is 21? There's nothing happens suddenly on the 21st birthday that you become smart enough to vote. Or why does the social security starts at 65 or whatever. So in real life we do use cutoffs. Similarly, for insurance reimbursement purposes, we use diagnosis. And the other, obviously the downside of categorization is that you use cutoffs which are arbitrary. So, and I will talk about that when I talk about the neurocognitive. So the hope is that in future we will have a really good way of characterizing the impairment on a continuous basis, and then we can do away with these categorizations. We are not there yet. Cognitive versus neurocognitive. Actually, we know generally in our own mind who is a psychologist and who is a neuropsychologist. We don't say that MMPI is a neurocognitive test or Rorschach is a neurocognitive test. So we say it is Wisconsin card sorting or Boston naming, etc. So the neurocognitive are those where actually we know the brain basis to some extent, more so than for cognitive testing in general. So that was the reason for using neurocognitive. Dementia. What is interesting is actually if you look at the Alzheimer's field, they insist on using the word dementia. And they said we have really over the last several decades, we have now brought people to think about Alzheimer's as a dementia. And if you remove that word, you'll lose all that history. There is some merit to that. On the other hand, when somebody develops major neurocognitive disorder as a result of brain trauma, like TBI or substance use or HIV, to say that person is demented is really not appropriate. So those groups says that we will not use the word dementia. So we had these two constituencies, so we asked Solomon what we should do. And Solomon said, okay, use both of these. So that's what we ended up doing. So we had neurocognitive disorder in parenthesis dementia. My feeling is that the word dementia will go out because it's a demeaning term. It literally means loss of mind. And we have seen even people with fairly advanced Alzheimer's who have good social cognition. Sometime back we celebrated 100th birthday of a woman veteran. She was in the Navy, and clearly she had moderately severe Alzheimer's, and yet she was still functioning as a lady. I mean, she was very aware of the social implications. So to call somebody like that demented, I think is pejorative and insulting. But we'll let the marketplace decide what happens. So that was the solution. And then lastly, neurocognitive assessment. Again, people came to blows over this. The neuropsychologists appropriately thought that we must have mandatory neuropsychological testing. How could you diagnose mild neurocognitive disorder without neuropsychological testing? We, for example, to diagnose mild hypertension, we have to have blood pressure, right? We have to have blood glucose for early diabetes. And here, for once we have something. That's not true for schizophrenia, depression, but here actually we have neurocognitive testing. Why don't we use that? Well, this is an example of when idealism runs into reality. How many places will have qualified neuropsychologists? Because the place like UCSD, we are really very rich with really neuropsychological expertise, but that's not true for many small places where there is not even any mental health expert for miles. Secondly, should we use a global assessment or domain-specific assessment? For example, do we only do testing of memory, or do we look at the overall neurocognitive functioning? Another problem is that the measures need to be non-patented. APA cannot, yes, because it's just like the federal government cannot recommend anything that is patented, because then you have to pay. So most of the neurocognitive tests are patented, including mini mental state examination. So when we do that clinically, nobody bothers, but if you are going to do that on a large scale, when the drug companies do trials using MMSC, they have to pay. Another problem is you have to have norms to use cutoff. Now you can say, okay, you give it to 1,000 people, develop norms. No. You have to have norms by age, by education, by language fluency, by culture from which they come, and their past experience with that kind of testing. All right? That's why there is practice effect, because you do the test again and again. So we need to have all of those things available. I don't think there is any test that exists right now that meets these requirements. And what are the appropriate threshold? It is between 1 and 2 standard deviation, whatever it is. And so clearly this is an area that needs further research. Okay. Now I'm going to run through this rather quickly because you can see them. So the main point I want to make is a major neurocognitive disorder, in parenthesis dementia, there is significant cognitive decline. This differs from mild neurocognitive, where it is modest cognitive decline. Okay. Now what is significant and what is modest? Ideally, modest means between 1 and 2 standard deviation, and significant would mean more than 2 standard deviation. This again assuming that we have the test and norm, etc. But that's really the eventual goal. this is important though, that cognitive impairment must be reported by the individual himself or herself or a knowledgeable informer of the clinician, and there should be some objective evidence. And ideally it should be some standardized neuropsychological testing, but in its absence another qualified clinical assessment. So some bedside test can be done. Again, APA, we refrain from recommending anything specific, because again the standards vary so much. So the suggestion would be that you develop expertise in one area, one particular test, whether it is mini-mental, clock drawing, whatever, but use that on a regular basis. If one can show decline in whatever you are doing, that would bolster the case for one of these diagnoses. And this is also important. It should be significant enough to interfere with independence in everyday activities, that is the instrumental activities of daily living. So things like paying bills or managing medications. So where the person cannot do that and needs somebody else's help. That is important, because when we look at the mild, there the person is able to do that, but with some effort and accommodation. Okay. So those are the two main things to remember: the significant cognitive impairment and that interferes with daily functioning. Without behavioral disturbances, severity, mild, moderate, severe. And then once you diagnose major neurocognitive disorder, dementia, the next thing you do is the likely etiology. And one thing that happens in this group of disorders that doesn't happen with most other psychiatric disorders is we know the neuropathology in most cases, and we often know the etiology. For example, this is Alzheimer's brain. This is of course pretty severe, and you can see the whole brain has shrunk. There is atrophy and the increased ventricular space and so on, and all over the brain. In contrast to frontotemporal dementia, where you see that mostly it is the anterior half of the brain that is affected, the posterior half is pretty intact. So here actually we can make a reasonably assured diagnosis by using some brain imaging. However, none of this is diagnostic yet. So that's why we did not recommend, I'll come back to that briefly later, but we did not specify any biomarkers at this stage because they are not of clinical use at this stage. They are of research use but not clinical use. Okay. That means, so Alzheimer's can be probable or possible, and then it describe how you consider probable versus possible. And if there are questions, I'll be happy to answer those, but let me. Okay. Then going to mild neurocognitive disorder. This is actually something that generated the most controversy within the field of neurocognitive disorders. Why? Because many people accused us of saying that we are creating a new category that is poorly defined, and we are doing it to help the industry. That people will then start using the cognitive enhancers for every single person, because can there be a 65-year-old who doesn't have some difficulty in remembering names, faces? So why not diagnose that person as mild neurocognitive disorder and give cognitive enhancer? So that was actually the main criticism. We use the word mild. Actually, mild is not opposite of major, right? So we have major neurocognitive disorder, opposite of that should be minor. So why not use minor? Talk about that. And thirdly, people from Alzheimer's group actually severely criticized us in the beginning, saying that we should not call it mild neurocognitive, we must call it early Alzheimer's. That is what it is, and that's the only way we'll be able to prevent it. So what did we do? Each of these three things. So the first regarding this is conflict of interest. So one thing is currently there is no FDA approved medication for mild cognitive impairment or mild neurocognitive disorder. So the criticism did not come from neurologists, because there are actually now literally hundreds and hundreds of papers on what is called MCI in the neurological literature, and of the neuroscience literature in psychiatry, psychology, but and clearly there is, I think most people do accept that there is such a thing, that between normal aging associated cognitive impairment and dementia is an intermediate stage. And if we can diagnose it, we can do something. That doesn't mean giving medication, but that's the way in which we can at least begin some preventive efforts. Minor versus mild. Minor actually was originally what we wanted to use as opposite of major. The problem we ran into is that people pointed out if you call something minor in DSM-5, insurance companies will refuse to reimburse. They will say this is not a real psych disorder, it's a minor thing. So, so we actually thought of several options. We thought of stage 1, stage 2, as is done in, for example, bipolar 1, bipolar 2, or in hypertension, also there are stages. But we realized that most people would not be able to do that. So we use mild. And lastly, why not early Alzheimer's disease? Because majority of the people do not, with mild neurocognitive disorder, do not develop Alzheimer's. It's a law of thirds. Third of the people with mild neurocognitive disorder will develop dementia. 1/3 will continue to be in that stage, and believe it or not, 1/3 will go back to being normal. So those are the people whose cognitive functions seem to be impaired during the testing, but it could have been because of depression or something else, and then they go back. So my job, as I said again, I want to explain the rationale why we made the decision that we did. Okay, so mild neurocognitive disorder, as I said, the cognitive decline is modest, not significant. Again, based on the individual informant or clinician's concern, plus some objective assessment. And there is independence in activity, however, greater effort, compensatory strategies or accommodation may be required. For example, to remember where I parked the car in slot 5, I would repeat that 10 times to myself, 5, 5, 5, 5, 5. So that's how I can ensure that I will remember it. So I'm doing extra effort. Or I may write it on a notepad and remember to read it. So accommodating strategy. So whereas in dementia or major neurocognitive disorder, it has gone beyond that. You don't even think about those. So you need somebody else's help. Okay. So again, the specification by etiology, we go through the same thing, Alzheimer's, frontotemporal, etc., etc. Again, probable, possible. I will say one thing, that for mild neurocognitive disorder, be very careful when you say it may be due to Alzheimer's, because we are then really labeling the person with Alzheimer's when we do not know whether the person will develop Alzheimer's. Mild neurocognitive disorder, as I said, in 1/3 of the cases can revert back to normal, in 1/3 it will continue to be the same. And even when a person develops dementia, it may not be Alzheimer's type. It could be something else. So, normal pressure hydrocephalus used to be a common example of reversible dementia. So be very careful in using that for mild. For dementia, it's a major, it's less of a problem because the signs are pretty often clear. So you really need genetic testing. There are some uncommon forms of Alzheimer's which are transferase autosomal dominant, where there is mutation involving beta amyloid protein or presenilin 1 or presenilin 2, or the strong family history, or PET scan showing increased amyloid plaques, etc. But at this stage, again, as I said, we have to be very careful in using the diagnosis. Associated behavioral disorders. This actually I felt was one of the disappointments for me personally, that we didn't go as far as we should have. I would have liked to have this opportunity actually to improve the behavioral categorization. These symptoms are really important. And as mental health professionals, we see these patients not often because of their cognitive impairment, which gets treated by neurologists or geriatricians, but for the behavioral problems. And psychosis occurs in nearly half of the people with Alzheimer's, depression in at least a third, and agitation is almost universal in later stages of dementia. 90% of people with severe dementia will have severe agitation that requires treatment. Unfortunately, that's one of the disadvantages of democracy, is that you have to go by what the consensus is. And so the consensus was not to go with more definitive criteria because we don't have enough evidence. But again, this is something that I think will change. So right now what we had done is, when you diagnose major or mild neurocognitive disorder, you say without behavioral disturbance or with behavioral disturbance. And with includes psychotic symptoms, mood disturbance, agitation, apathy, or other behavioral disturbance. Other behavioral disturbance may include sleep problems, hypersomnia, insomnia, screaming, wandering. And these are really, studies have shown that these behavioral problems that cause institutionalization, not dementia, not incontinence, but the caregivers give up when the person starts accusing them of having an affair with the next door neighbor, or they say you're poisoning my food, and so on and so forth. So this is really an important area, and I hope that we do a better job in 5.1 or 5.2. So going to the summary. So the main changes in neurocognitive disorders from the DSM-4 are these. One, we specified mild neurocognitive disorder. DSM-4 actually had mentioned something like MCI, but it was under cognitive disorder NOS. So we thought that in the last 20 years, there is so much literature on this category that we really need to have that as a separate category. Secondly, we now need objective cognitive assessment, not necessarily neuropsychological testing, but at least bedside assessment, that there has to be documentation of neurocognitive impairment based on anything that you do, whether it is just asking 3 words and asking the person to repeat them in 5 minutes, or clock drawing, or mini-mental state. We removed memory impairment as an essential criterion for neurocognitive disorder. The reason was that in non-Alzheimer's dementias, memory impairment does not occur until much later. For example, frontotemporal dementia, the main symptoms are related to personality functioning. So loss of empathy, antisocial behavior, loss of judgment, insight, etc. Memory is not affected until much later. So we removed memory impairment as an essential criterion. Slightly better specification for behavioral symptoms, but really needs to be better. Another thing here is actually for that you can have impairment in one domain and still you can have dementia. In DSM-4 you usually require 2 domain impairment. I mean, one good example of that is amnestic disorder, what used to be called amnestic disorder, where there's only impairment in memory. That would not have made criteria for dementia or major neurocognitive disorder, but now with one domain impairment being enough, that can still be a major neurocognitive disorder. What about biomarkers? Some fabulous research going on in terms of this amyloid PET imaging, CSF tau, CSF beta amyloid to tau ratio, and really studies, increasing number of studies are showing that to some extent we can predict who will develop Alzheimer's. However, the sensitivity and specificity of this is not adequate. If somebody has this abnormality, that doesn't mean that they will develop Alzheimer's. On the other hand, without this, they may develop Alzheimer's. So that's why we did not think that this was ready for prime time for clinical diagnosis. At the same time, I think this will be, I expect that in the next few years, we will add one of these biomarkers to one of the neurocognitive disorder criteria. Actually, there was a period when Medicare was funding the use of PET scans, but I think now I think it is being questioned. Genetic testing is not recommended at this stage. ApoE4, I think most people know, is associated with increased risk of Alzheimer's, but increase in the sense that it's only 40%. So still, many people with Alzheimer's don't have ApoE4, and people with ApoE4 may not have Alzheimer's. As I said, the field is moving fast, and one or more of these biomarkers will be incorporated in the clinical diagnostic criteria in the near future. So this is my last slide. So I started out with all the problems that we faced, and so I think largely DSM-5 is concerned with current scientific understanding of most psychiatric disorders. I think some of the criticism of DSM-5 is fair because many of these are subjective judgments on the part of experts. For example, I mean, what diagnostic test should be used, whether you should have some biomarkers, whether when we require duration of symptoms for say schizophrenia, how do we know that that's is it 6 months, why not 5 months, why not 7 months? So there are things over which people can disagree, and so I think so. This is not you cannot have a perfect document of this type when we don't have valid biomarkers with which to confirm the diagnosis. So some criticism is fair, but I think some of it is unfair. I really don't think most people, we all were sitting there with the idea of helping the companies that was supporting. Actually, 72% of the people involved on the work group and task force had zero industry relationship, and myself included in that. Of course, major changes when you make the changes, and there are some major changes here. For example, autism spectrum disorder, including the mild neurocognitive disorders. So changes are always difficult in the beginning, but they are inevitable. We don't have a choice. As the science advances, the changes will occur. But the goal is that the future revisions will not be. So we should not have to wait for 15 years or 20 years to come up with change in the whole document. The changes can be incremental, because that's what happens with science. I mean, taking neurocognitive disorders as an example, we know so much more about Alzheimer's. We don't know so much more about delirium. And our knowledge about delirium has not changed that much in contrast to Alzheimer's. So these changes will be on a small scale basis affecting specific disorders. But this is actually an important thing that psychiatric diagnosis will be increasingly driven by scientific advances, but instant feedback from the community. As I said, when you talk about changing the diagnosis of cancer, you don't ask the community. I mean, you ask the community in terms of treatments, clearly, or procedures like mammography. So that can be an issue of controversy, but not whether somebody should diagnose as cancer. That's not true for depression, where there is bereavement, exclusion, mild, etc. So personally, actually, I started out by saying this, my love affair with DSM-5. I'm glad to say that it has ended. We are ended on a friendly basis, and we'll go from there. So let me stop here, and thank you.